excluded. We'll look at some of these objectives tonight where there are some exclusions. In the menu set, where the provider can defer 5 of the 10 objectives, if there are some exclusions that they can claim there, those exclusions will not count against the total number that they have to, objectives they have to meet. If you can exclude 3, then that doesn't mean you have to replace them with other ones. That would just mean you only would have to select 2 of the menu set objectives, at least one having to be a public health objective. So we're going to focus on interoperability and exchanging the data outside the clinic, as we mentioned earlier. A couple of terms, always good to define the terms that we're going to be talking about a little bit tonight, because some of these objectives are based on how these terms are defined. Transition of care, defined by CMS as a movement of a patient from one care setting to another. That's as simple as it could be. Going from a hospital back to their primary provider, or going from primary provider to a specialist, or from home health or to long-term care. Those are the transitions of care from one care setting to another. Public health agency, entity under jurisdiction of the Department of HHS or some other organization that serves a public health function. We're going to see some reporting requirements coming up in some of these objectives tonight. Diagnostic test results, pretty wide variety of how these are defined, not just only our chemistries, but urinalysis, pathologies, radiology, everything all the way up through pulmonary function testing, all considered diagnostic test results in terms of meaningful use objectives. And different legal entities. We'll touch on this a little bit, where we talk about the breakdown of the different legal entities and how that will affect some of these meaningful use objectives. Certified EHR technology. One of the, of course, 2 core requirements of the CMS EHR Medicare and Medicaid Incentive Program is certified EHR technology and meaningful use. It's kind of interesting that all last year through 2010, the whole focus was on certified technology. There was no certified EHRs, no certified EHR modules out there. Who was going to do the testing? A lot of anxiety in the market until that was finalized. And now there are considerable numbers and more every week of complete certified EHRs for hospitals and as well as for eligible providers. A lot of certified modules, standalone modules. And the focus really has now shifted beyond certified EHR technology to the actual use and documentation of the use. So we really moved into a new area here. Exchange, really we're talking about the exchange of information. These could be exchange of clinical information between 2 medical practices, between a medical practice and a hospital, really almost any 2 or more entities with different EHR technologies. We're going to see a lot in stage 1, where the requirements for the type of exchange that's being defined here is extremely simple. It's just another word for it. Very, very simple. And the tests that are required for stage 1 are pretty unbelievably simple and very, very easy to achieve. And so the type of exchange that's going on in these meaningful use objectives for stage 1 is not, in most instances, true exchange of real patient data. It's more or less an exchange, sometimes not even successful, just to make sure that the plumbing and the pipelines and the infrastructure is being put in place for the HIT highways and superhighways that everybody's counting on to be in place 5 years from now. Patient authorized entities, these are any individual organization to which the patient has granted access to their clinical information. Of course, everybody immediately gives access to their insurance company. The insurance company won't cover with a policy, but it's also being able to assign permissions to your physician to deliver information to your or other providers to your personal health record, permissions to exchange information from one of your physicians to another physician, and that it is required that patients have to really grant access in an affirmative manner to these entities. Most medical practices, when you register as a new patient, that's one of those 5 or 6 sheets of paper you sign saying you give them authority to release your clinical information to anybody that really that they deem needs it. First core objective that we're going to talk about tonight is the electronic exchange of clinical information. In the future, 5 years from now, we are hoping, I'm hoping, and I think the whole HIT interoperability dream is that if someone goes to see a provider and that provider documents a clinical encounter, that that patient's record or portion of their record, or at least some information about that clinical encounter, will be transmitted to a health information exchange network. Since we live in a political world, the federal government is funding these HIEs on a state-by-state basis. And so in North Carolina, where I live, the dream is that 5 years from now, when I would go see a physician of any kind, that visit would be documented, and then an exchange file carrying that clinical information would go to the Health Information Exchange, dated, time-stamped, saying what provider had generated that information. And if a day or a week or 10 years later, my next visit to a physician, they could go to that Health Information Exchange and bring down that information on me, bring down that file. So to me, that is the real goal of the electronic exchange of clinical information, that it can be shared in very structured manner. Again, that's perhaps 5 or more years from now. What's required for stage 1 meaningful use for the providers? And again, the objective, the base objective, is the capability exchange key clinical information. That's defined as the problem list, medication allergies, and diagnostic test results. A very, very short list there. Not talking about a surgical history, not talking about procedures, not talking about environmental or food allergies. But just a very relatively tight core set of key clinical information. And for stage 1, for 2011, the measure is that there must be at least one test of your certified EHR to electronically exchange this key clinical information. So the requirement, the threshold, is not a percentage here. It's either yes, you tested it one time, or no, you didn't test it one time. And so regardless of if you're would be a general practitioner or a specialist, or you never see patients, that would not allow you to claim this as an exclusion, because there's really no way this could be outside the scope of practice, because the only thing required is one test to exchange some of this clinical information. One thing that's actually fascinating about this, having to perform at least one test, the test itself does not even have to be successful. Some additional information, this is from CMS. The the actual test must involve the transfer of this information that really includes at least these 4 areas we discussed on a particular patient to another provider of care who also has certified EHR technology. And that would, any certified EHR, complete EHR, can generate these files, can transmit these files, and can receive these files and read them in a human readable manner. They can be shown on the screen, and it looks like a patient's record. It's not just digital information. Mentioned earlier, the second bullet there, transmission of actual patient information not required for purposes of this test. Test information could be a fictional patient. So it's really just some dummy data more than anything else. When the clinical information is available in a structured format, it should be transferred to structured format. When they talk about structured format, these types of particular clinical interoperability exchange files go by the terms of CCD or CCR, continuity of care document, or continuity of care record. These are specific types of file formats that contain information about one person, some names, some demographic information, and some key clinical information. It's the kind of information that some people carry around on a 3x5 card in their wallet or in their glove box, just that very core snapshot information on an individual. And it's these CCDs and these CCRs that we hope 5 years from now will be the molecules that that create these health information exchanges. They'll be the lifeblood, be the corpuscles. If during the test, if the information is unavailable in a structured format, the transmission of unstructured data is permissible. Exactly how these tests are to be done, I don't know. I've been looking for guys from CMS, whether there'll be some ways that something can be set up with your certified EHR vendor to test it against them, or there'll be some other ways that there'll be a test procedure and test protocol so practice can actually attest that they were able to create this type of structured data, or if they can't, at least unstructured data, and attempt to exchange it. It's like a practice for 2011. And it's up to the eligible providers to use their judgment as to what is clinical information. It's really interesting that where we are at stage 1 is they're trying to really take baby steps here in the requirements. And so they're saying, we're not really going to even tell you what clinical information is, but we want you to try and create a file out of your certified EHR and exchange it somewhere else. And it doesn't have to be real data, and we just want you at least try and test it one time this year. Well, there actually is a requirement that must be attempted to test successfully this year. So pretty low threshold here. The other interesting part about this is that the ability to test this only has to be done once prior to the EHR reporting period. And as long as this test occurs at the beginning of the period or sometime during the payment year, that is considered fine. And this is one of the few exceptions in which, rather than this meaningful use objective has to be met on a provider-by-provider basis, if multiple providers in a practice are using the same certified technology, testing really only has to occur once. So if it's tested in the practice, then all the eligible providers, regardless of how many there are at that location, can attest that, yes, it has been tested. And again, kind of fascinating, the last CMS point that an unsuccessful test of the exchange of key clinical information is considered valid. So they just, for this one, they know we're getting into an area with interoperability where very few practices, very few hospitals have ever been. and they're just trying to take one little teeny baby step here for 2011. However, I'm very confident that by stage 2, 2013, and then stage 3, the standards around this, once they're totally worked out, are going to be much more robust. Next objective is one of the menu objectives, transition of care summary. This is certainly not a new workflow at all. A provider sends a patient to the hospital or to another provider or to a rehab facility or some surgical center in another state. They usually send along some information. And that workflow is directly reflected here. The objective is that any eligible provider who transitions their patient to another setting of care or provider of care or performs a referral should provide a summary of care record for each transition of care. That's been standard practice probably since the days of Hippocrates, I would imagine. The measure is that if you are the eligible provider who's referring their patient out or transitioning the patient over to somebody else, you have to provide the summary of care records for at least, for more than 50% of these transitions of care. The exclusion is any provider who doesn't transfer patients to another provider or to another setting. So some specialists that really are perhaps not involved in direct patient care, but are still eligible for the EHR incentive program and maybe in a specialty where they're not transferring patients anywhere or sending them anywhere. They would simply be able to exclude this particular objective right here. Again, one thing that kind of keeps coming back up for me is where are these numbers really going to come from? Nobody has been down this road yet. Certainly the Medicaid program, which is on a state-by-state Medicare incentive program, state-by-state basis, requires no meaningful use objectives to be met in the first year. So the first, second week of January, some Medicaid providers received checks. However, in the Medicare system, since there's at least a 90-day period of time that's required during the initial year, if they're ready January, February, March, maybe apply in April, maybe get a check in May, depending on quite a few things. But nobody yet, no Medicare provider yet, has had to sit down or have somebody else sit down and try and come up with these numbers. Some EHRs, in a very elegant fashion, can come up with these numerators, denominators. Other ones, it's not so simple a process. And some EHRs require some workflow outside the EHR to keep track of some of these measures. Requirement here again is that at least, more than 50% of these transitions of care that take place require a summary of care to be provided. Now, it is up to the provider to decide when a transition of care has actually occurred. Only patients whose records are maintained in the certified EHR should be included in the denominator of transitions of care. The transferring party, if you're the provider transferring somebody out, then you're the one that must provide a summary care record. And a little bit of leeway here, but again, this is a common workflow. Consider electronic. You could almost any way that you want to send the summary care record, including printing it out and handing it to the patient to take to the specialist or the hospital, wherever they're going, is fine. So there are some instances where the summary of care record does not need to be provided. under certain certain circumstances, the provider to whom the referral is made or is receiving the patient already has access to the medical record by maybe a community-based electronic health record or some type of other exchange where they can dip in and pull up these records themselves, then that transition of care doesn't really need to be counted in the denominator as a transition of care. Next meaningful use objective kind of falls in that interoperability category is immunization registries. I work with a lot of different EHR vendors, and quite a few of them are specialists, and one of the first things always is our users don't do immunizations. and so how can they expect us to do that? And of course we know now that particular specialists and well, actually, many specialists do know immunizations, and that's quite all right because they're excludable. However, the technology has to have the ability to not only document immunizations, but to generate a certain type of electronic file to an immunization registry. So the objective here is that immunization data can be submitted as an electronic file to an immunization registry. And that submission has to occur to the applicable law and practice, which varies state by state and city by city. There are, when the certification process got ramped up last year, and they found it very difficult to test this because there's so many different interfaces and specifications around the country. Some cities have their own electronic registries, New York, for example. Some states by themselves don't have an electronic registry. It's all paper-based. The requirement for immunization reports from pediatricians and similar practices to fill out pieces of paper and mail those in once a month where they're collated, or hopefully they're collated. So this, for stage one, had to be as broad as possible. So again, the measure, very similar to the exchange of clinical information, is that there has to be at least one test of the certified EHR's capacity to submit electronic data to immunization registry. If the submission, if it's a successful test, then they have to actually submit the data. The caveat there, the exclusion there in the measure, unless none of the immunization registries to which the provider submits such information has the capacity to receive the information electronically. It varies very widely all over the country right now. But there is certainly a core exclusion here: no immunizations being provided by eligible provider automatically, or where there's no immunization registry. This is a exclusion just right out in front. We've already covered this. This is just a yes or no, and a very broad capability to exclude this, especially for specialists. And the test, very similar to the clinical exchange files that they're talking about, clinical exchange information. Exactly what is going to qualify as a test and what has to be documented as a test during the application period for the incentives. I haven't seen the details on that yet, and I certainly look for those details on a continual basis. But I'm sure sometime in the next month or so, CMS is going to roll out some guidance and some regulations around the capability of how these tests need to be performed. Again, actual patient information is not required for this test, and it can be certainly just a fictional patient. And just like exchange, if a clinical exchange, if there are multiple eligible providers, this is a second case where the test does not, the objective does not have to be met on a provider by provider basis. If the practice test at one time and they attest to that, that's good for all the eligible providers. Also, again, we run into that interesting fact that an unsuccessful test is valid and satisfies this objective. So the test does not even have to be successful. It makes me laugh. Maybe stage 2 is going to be have to do it successfully, or maybe that's stage 1.5. I'm not sure yet. If the test is successful, then the eligible provider should institute regular reporting with the entity with whom this test was conducted in accordance with applicable law and practice. And no measurement or percentage measurement is associated with this reporting for stage 1. The actual transmission of this information is based on some specific technical specifications, and every complete EHR, certified complete EHR, O&C authorized testing certification body certified EHR has documented that they can generate these immunization files in this particular standard. This menu objective also is reporting, registry-based, and interoperability, kind of all thrown in together. Kind of an interesting one to me, syndromic surveillance data submission. After working with certified EHRs for about 5 years, and I had never seen one that had the capability to submit syndromic surveillance information. I'm sure it's very common in hospital EHRs, but I've never seen it in an ambulatory EHR. And all of a sudden in stage 1, there's this requirement. Again, this is a menu objective, so it can be deferred. For stage 1, also it's excludable. But the objective is the capability to submit electronic syndromic surveillance data to CDC or a public health agency and whatever other entities according to applicable law and practice. What this means in the real world and in real language is if I was seeing patients or if I was in an area in which the local health department wanted every time I documented a patient with a particular diagnosis, let's say H1N1, that I could either, when I gave somebody that diagnosis, push a button and generate one of these surveillance data files that I could send to somebody if there was somebody to receive it on the other end. Likewise, a side functionality would be if I, in my database of all my patients, wanted to generate a list of all patients who had a particular diagnosis. That could be a diagnosis, perhaps it had to do with some type of epidemic or some other type syndrome that was a real public health issue. I could search my database and then generate one of these acceptable electronic syndromic surveillance files. Every certified EHR, complete EHR, under stage 1 meaningful use has the capability to generate these files. They do it in some different ways, but they all have the capability to generate these files. I could see the real advantage of this type of data, again, maybe 5 years from now, where if every time an individual, whether it's a hospital or really any healthcare contact, is given a particular diagnosis, that information in a dynamic sense could be generated to an entity like the CDC for that real-time reporting to see what's happening across the country as far as public health. I see the real value of that. But again, we're at stage 1, so the only capability is that we could generate one of these files for a test. It's a yes or no. Again, this is just a test to see if one of these files could be generated. Exclusions are that if eligible provider is not collecting any of this type of reportable syndromic information, or if there's no public health agency that has the capacity to receive the information electronically, then you're excluded from this requirement. And certainly for the first year, this is not only easy, one of the deferrable items. Have to do on the public health area, the syndromic surveillance, as well as the immunization registry. You can pick 5 out of 10 menu set. For the 5 that we do not defer and we elect to do, it either have to elect to do this or have to elect to do the immunization registry. Of course, then both of them can be excluded. Very similar to clinical information exchange. We have to actually try and, during the test, involve a true submission to an entity who can receive these files. This is done routinely in many parts of the country. I know New York City, in particular, and probably numerous other places that are geared to accept the health departments or their registries to accept this type of information. The electronic formats are well worked out, and they receive this information again dynamically from EHRs in their area. Certainly not on a national basis yet, though. Also, an unsuccessful test is considered valid. They just want us to push the button and try and at least push the button one time and try and make this work. If the test is successful, then those providers should institute regular reporting with whoever that successful test was conducted. However, since this is based on perhaps a county by county or region by region or a state by state basis as to what type of syndromic surveillance, if clinical data or diagnosis or problem list is being tracked. When it is being tracked right now, it's usually paper-based tracking. This is a stepping stone to move that to an electronic level. Certainly would make things, the reports available much quicker. And no measurement associated with this reporting. You either test it once or you don't. Also, multiple providers, as we mentioned with a number of these cases, if they're at the same location using the same certified EHR, this test only has to be done once for the whole practice. That's it. Standards have been worked out in great detail about syndromic surveillance. Right now, there's a particular coding requirement for stage 1. A certain type of HL7 file must be generated, and every complete certified EHR, stage 1 meaningful use EHR, has the ability to generate these files in the correct code. Always good to talk about different resources. Incentive roadmap, this is the manual that I wrote with a little help from my friends to help medical practices, ambulatory practices, put together their own strategic roadmap to the incentives, Medicare or Medicaid incentives. First version came out about 4 months ago, and it's been updated on a regular basis and will continue to be updated on a regular basis, just putting quite a bit of content about meaningful use for specialists. The virtual extension center, anybody who's listening now or listening to this later, the recording of it is most likely already a member of the virtual extension center, hightechcancers.net. That's where I provide a lot of my support for meaningful use and trying to answer questions. The whole area of meaningful use is a moving target. It's not zigzagging so much, but it's always seems like half a block ahead of us. So when we get all the questions answered for this week, next week there are going to be some new questions. So this really is a 5-year ongoing process. Very exciting, actually. You know, hope it's somewhat exciting for those of y'all in clinical practice, because to be part of a movement like this, going from a paper-based world to electronic world, 10 years from now, we'll look back and say, wow, look at all that happened in that 5-year period. But a lot of recorded webinars at the Virtual Extension Center, did one several weeks ago that's there about meaningful use for specialists. And then, of course, the CMS website. A lot of details there on the Medicare and Medicaid program. I check it once a day. I keep checking it because I want to find out when they're going to release the form so we can see exactly how a practice, an eligible provider will attest to these different measures. So a lot of resources out there, and in particular for specialists or subspecialists, the importance of finding information maybe from your peers or your specialty associations who really are focused on teasing out those very, very difficult answers to questions about what can be excluded, what can be deferred, how you can really set yourself up so that as you go through stage 1, you're really preparing yourself for stage 2 and beyond stage 3. Thank you for listening tonight. Carol, I'll turn it back over to you. I think we've got time for a few questions and maybe 1 or 2 answers, hopefully.
Yep, we've got a few questions. I have to tell you and the attendees that I think that we should start promoting stage 1.5 meaningful use. That might go viral, Jim. All right. So yeah, we've got a few questions. You ready?
Sure.
I guess so. All right, let's go. So the first question, this sort of goes back to the first objective you were talking about. Can the test of the capacity to electronically exchange key clinical information be applied to all the EPs in an organization, or does it have to be done separately for each EP?
Well, this shows to me that whoever's making these regulations was thinking about providers. And so the answer is, each eligible provider does not have to. Requirement is that if it's one setting, one certified EHR, numerous providers, there only has to be one test, and then all the providers can base their attestation on that one test. There doesn't have to be a test for each eligible provider.
For the electronic exchange, do you have to report to whom you sent the data, i.e. the other provider, or is it just a yes, no, and done in good faith?
That's a great question.
That's a great question.
Right. And since this first year is a test, and again, I haven't run across that question yet, but my gut reaction to that is, no, we don't have to do that. I think it's just going to be an attestation.
Right.
Now, again, we really do need some guidance from CMS, and I've asked for guidance from CMS, and we'll see who gets it first, how they expect these tests to be done. And kind of the question, what kind of documentation do they really want from these? So, again, that's one of those, that's guidance that maybe is half a block ahead of us.
It's the work in progress, right?
I think so, sure.
Yeah.
Mm-hmm.
And I'm actually not really sure which the attendee who asked this question, which objective they were asking about, but maybe you can chat it to me. Where do you send the transmission of patient information in order to meet this objective? I think that might have been the first objective.
Let's see, right, well, that was kind of just very similar to a question that we just discussed a little bit.
Yeah,
that's
right.
Trying to change of clinical information.
Yeah,
I don't,
right.
I don't know yet.
We're
they
gonna,
haven't told us yet.
Yeah.
How this test can take place. If they made me the czar of meaningful use tonight for 1 hour, I would have the government just set up some testing entity where you could create these files and send these electronic files and ping them off some testing body someplace and receive a file back, or at least proof of submission.
Right.
But I don't think they're going to make me the czar tonight. And so I don't
would
know how
work
they're
for
going to.
that.
Yeah, thank you. I don't know how they're going to do that. And they're going to have to give some guidance and really a plan to do that.
Yeah. Are the syndromic, syndromic information being collected defined? And if so, is this a list that can be located?
You know, that is, for the purpose of meaningful use, the only requirement is that the functionality exists to generate a file that is based on a patient diagnosis. And so it's really outside the scope of meaningful use to identify a particular diagnosis at all. As to, again, if at some time in the future there's some type of public health interest and entities that are involved saying this is the IC9 code or the SNOMED code we need reported, at least the functionality will be there. But the actual content of what that diagnosis is outside is outside the scope of the meaningful use right now. I just want to make sure we can generate one of these files that's really based on a diagnosis. And for the testing capability, when the certified technologies EHRs are tested to demonstrate this, whether they use influenza or heart disease or some type of glaucoma, it doesn't really matter. They're just looking to see that the functionality is there, that with the input of a particular diagnosis, a certain type of file can be created. So they're just creating the structure now, I believe.
Got it. And this last question, which is the last one we have for this evening, this actually came up in a previous session that we had, and so I think it bears repeating again. Who ultimately is responsible for the numerator and denominator numbers, the certified EHR or the EP?
EPs.
Yeah. Everybody needs to know that, right?
Right. And so much of this, to me, is a workflow issue. The vendors, their job is to supply certified EHR technology, and the EP's job is to use it in a meaningful way. Now, the whole area about where this data is coming from is my idea is that a really good EHR, part of their outreach and support of their customers, what it needs to be is training and whether that's PowerPoints or however they do it, or documentation of how to use, with screenshots associated, how to use their EHR to meet different meaningful use objectives. Just go ahead and show your users how to do it and document that. Right. Now, the one thing that is a little bit of the wild card here is these numerators, denominators. That is a part, the ability to perform what they call, what ONC calls automate measure calculation, to generate these percentages, these threshold percentages. The ability to come up with that percentage is required for a complete certified EHR. However, where the numerator and denominator actually come from the standpoint of certification, it can be a totally manual process where the EHR just has blank fields, where the provider, somebody, has to somehow keep track of all this stuff and then type in numbers, actually come up and put in those numbers. And so that is certifiable. So some EHRs, it's a totally 100% manual process. Other EHRs have automated this process. And so they are doing queries to their database to bring up these numerators and denominators. And it's not an easy thing to do. because to generate some of these numerators in particular, it requires the provider to provide input. They have to actually document whether something is a transition of care or not, as to whether it would actually be in the denominator. So very wide variety of where these numbers are coming from. And I think sometime in the next few months, or next 6 months, this is going to be more and more of an issue, and there has got to be certainly workflow, depending on which EHR that you have, to help figure out how to come up with these numbers. Because just getting the technology and using it, it may generate the numbers for you, it may not. I'll give you just one more little example there. I think we talked about last night. A requirement that for e-prescribing, if you don't exclude it, because maybe you do more than 100 prescriptions in a reportable period, the denominator is all prescriptions. The numerator is how many you e-prescribed. So that denominator is made up of electronic prescriptions, e-prescribed prescriptions, as well as handwritten paper prescriptions. Somebody's got to count prescriptions. Now, the best workflow is just say we're not writing any paper prescriptions and do them all electronic, and it's just going to be 100% all the time. But there's some areas where workflow and foresight will be the only thing that can save a lot of work down the road.
Right, right. And it's good that we actually are, for those of you on the phone or listening to your speakers, computer speakers, we actually are going to be, I think, developing sort of a pretty robust event series related to workflow, because these are questions that the EP should need to ask their EHR, like don't take it for granted, basically. Yeah.
Yeah, that's correct.
Right. Well, Jim, listen, you have a great Friday and weekend, and we will gather back again on Tuesday night at 7 p.m. Eastern Time for Part 4 of this series. Thank you so much, and thank you, everybody, for attending.
Great. Thank you.